In this video, I will be talking about anticoagulants, antiplatelet drugs, and its impact in dentistry. Our focus will be in the relationship between these medicines and dentistry procedure. At the end, I want to answer the main difficulties that dentists encounter concerning this subject during their clinical practice. Now, in order to make things clear, it is important to distinguish antiplatelet drugs from anticoagulants. In fact, antiplatelet drugs are used to inhibit platelet aggregation as a preventive treatment to thrombotic diseases. They are more effective in arterial circulation than anticoagulants. The most common one is aspirin. On the other hand, anticoagulants, commonly known as bone thinners, are the type of medicines used to prevent coagulation by inhibiting specific pathways of the coagulation cascade. There are three types of therapeutic approaches, with warfarin, with heparin, and with directly acting oral anticoagulants. To give you the best information available, I have searched in the literature for systematic reviews concerning this topic. In order to systematize the information, I will answer some of the most common questions that dentists have regarding this topic. The first question is, should we maintain or interrupt the antiplatelet drugs? The literature says that for any type of surgical treatment, antiplatelet therapy should be maintained. In fact, they say that dental procedures with maintenance of antiplatelet therapy are rarely associated with relevant bleeding complications. The second question is, should we maintain or interrupt anticoagulants? As I said before, there are three types of therapeutic approaches. With warfarin, if the value of ENR is under 4, the anticoagulant therapy should be maintained. However, if it is over 5, the patient should be referred. With heparins, patients should go see his family doctor before dental appointment. With directly acting oral anticoagulants, the therapy should be continued during surgical procedures. However, for procedures with high risk of bleeding, the suspension should be considered. The third question is, are there any pharmacologic interaction with these drugs? The literature shows that antibiotics can change ENR values, non-steroid anti-inflammatory drugs potentiate anticoagulant activity, medical herbs and supplements can affect the risk of bleeding. To finish, I would like to give you some really important notes. To patients taking anticoagulants or antiplatelet drugs, hemorrhagic phenomena that may occur are easily resolved using local hemostatic agents. It is important to request ENR values 24 hours maximum before surgical procedure. In stable patients, it can be extended up to 72 hours. We, as dentists, have the responsibility to do a traumatic surgery technique with limited operating field to promote primary wound closure and use local hemostatic agent. In concern of postoperative pain control, we should prescribe paracetamol and avoid the non-steroid anti-inflammatory drugs. So, it is really important for every dentist to have this information in mind to treat our patients the best possible way.